Good afternoon. We are starting our session, and this session is question and answer session. Please make a note that this is a question and answer session and not a course right now what we are conducting. This question and answer session we are taking for those who are registered with us for different server-based courses, different online server-based courses. So repeating that don't take this as a course. This is a question and answer session for those who are already registered with our course. So what we are doing, we are adding these candidates, these ongoing registered candidates in a WhatsApp group, in a batch WhatsApp group, and then we are at regular intervals taking these questions, and these are the questions for today. I am having a printout of these questions, but for display, I am showing you the questions. The language is original. What I mean by language is original, as we got the questions, so we copied and pasted it. So the language is original. As we copied and pasted these questions over here. The first question from Dr. Saida Bushra from Saudi Arabia is that she's writing, "Hi sir, sometimes we see reports like bulky cervix." Now see, sometimes we see reports like bulky cervix and chronic cervicitis. How to assess a cervix in these cases, and what is the cutoff value to recognize these? This is the first question by Dr. Saida from Saudi Arabia. Next is that kindly guide what it could be. It is a 35 weeks priming gravida. There is mild dilatation of gut loops with echogenic bowel at level 2nd 20 weeks. So she has taken a scan and she has sent us the clip also. We will play that clip and we will discuss what that is. And she wants to know what that clip is about. Third question from Dr. Ajoy Kumar is that how to visualize a suprarenal gland. So he wants to know where these adrenal glands are and how to see for these adrenal glands. Then Dr. Nisha is posting the question that what are the steps for the level 2nd scanning? And the next question from same Dr. Nisha is that what is a biophysical profile and how to see for it? So she wants to know about the biophysical score and the steps for the level 2nd scanning. Dr. Jagdevi is posting the concept of mirror image. So she wants to know about the mirror image. There is a something which is called as the mirror artifact or a mirror image. She wants to know in more detail about this mirror image. And the second from the same doctor is that edge shadowing not clear. So she wants to get more clear with the edge shadowing. So that is what she is writing. Kindly please explain this. Then the next Dr. Imran is posting how to differentiate between a hyperechogenicity due to a renal stone from a hyperechoicity due to renal sinus. So he wants to say how we can differentiate a hyperechoic renal sinus from a calculus. Second question from Dr. Imran is that how to measure a stack form calculus. And the third is how to grade the fatty liver. So let's take one by one. First of all, I told you that we have received a clip. And the doctor wants to know what that is. I am playing the clip, whatever I got it. I don't have doctor's name with me. So anyhow, this is the clip over here. Now, this is the fetal abdomen over here. This is the fetal abdomen. This fetal abdomen is showing some fluid over here. And these are the gut loops over here. So this is a level 2nd report. What she is doing, she is actually taking a level 2nd at 20 weeks. So this is the list of the questions I am reading from here. So she is taking a level 2nd scan of 20 weeks fetus. It is 35 weeks priming gravida. How it can be 35 weeks priming gravida? echogenic level. So anyhow, this is the fetal abdomen where we are having, I am playing it again, where we are having this black area, I will say, because she is not very clear what that is. So there is probably second clip also. Yeah, this is the second clip of the fetal abdomen. Now, what that can be, you please post, let us get more interactive, what this can be. So you can post in the comment box. I am keeping an eye on the comment box over here. So you please say what you are seeing over there. Hurry up, please, in your comment boxes now. So please post in comment box, I mean the chat box, what you will label this fetal abdomen as. Hurry up, please. So this is a level second scan of 20 weeks. What that can be. Hurry up, please. Now I am getting replies that this is ascites from Dr. MD Nordal. So MD Nordal is posting that this is fetal ascites. Next is posting Dr. Varitika Singh, stomach bubble. Then Dr. Gayatri is sending that this can be a case of hydrops fetalis. Then Dr. Harshita is sending me that this is the stomach bubble. Okay, hold on. Enough of your comments now. I've got an idea. First of all, is this a stomach bubble? Now see, is this a stomach bubble over here? No, this is not a stomach bubble over here. Now see, kidney is over here. This is the gut over here, and the liver is over here. So this is the clear case of ascites. This is the clear case of ascites over here. This is fetal ascites. Next question from the same clip. What are the causes of fetal ascites? So please post in the comment box. What can be the causes of fetal ascites? Hurry up, we don't have much time. What are the causes of fetal ascites? In your comment boxes now. Hurry up. Repeating. Causes of fetal ascites. Dr. Ekta Tiwari, hydrops. So very good. Hydrops is the main cause, I will say. Main etiological factor, main cause of this fetal ascites. So hydrops. What next? What next? Hurry up. Dr. Ekta has posted hydrops. So what next can be the cause of fetal hydrops, fetal ascites? First is hydrops. Next, in our comment boxes now, please hurry up. Dr. Rajesh, renal agenesis. Dr. Vasala, viral infections. Dr. Varitika, liver abnormalities. RH incompatible. Dr. Fatima, Dr. Rakhi infections. Dr. Nidhi torch infections. RH negative isoimmunization. Dr. Ekta and torch infections. Hold on. Now let us see over here. I have already compiled all these things. Now see, anything, any condition that results, now see, any condition, try to understand, any condition that results in fetal hydrops can be the cause of fetal ascites. So any condition that results in hydrops fetalis. Now additional causes are bowel perforation, ovarian cyst rupture, intrauterine infections. Now, what is a hydrops? Hydrops fetalis is an excessive extravasation of the fluid, which could be due to, now try to understand, which could be due to heart failure, volume overload, decreased oncotic pressure, or increased vascular permeability. So the point here is that main cause is any condition which leads to fetal hydrops. So concluding this clip, this is the case of fetal ascites. not a prominent stomach bubble. It is not a stomach bubble. It is ascites, and the main cause of the ascites is the hydrops fetalis, and the hydrops fetalis is due to heart failure, volume overload, decrease on contact pressure, etc. Now, next question. Next question is that next question. What is next question? Just hold on. Next question is from Dr. Saida Bushra from Saudi Arabia is posting. Sometimes we are seeing bulky uteruses, bulky cervix. When I can label that this is a bulky uterus or a bulky cervix? Very simple. I should know what is normal. I mean, how much is normal. And if that exceeds, then we can label it as a bulky cervix or a bulky uterus. Now, I should know how much is the uterine size. Here is the uterine size. Uterine size, this is already in the gynae ultrasound course. You have to see for the measurements, and the measurements are 7.5 in length. I mean the uterus. Uterus is 7.5 in length. Then widest part, widest in wide, I mean from right to left, wide, it is 5 centimeters. And now whenever it is crossing this measurement, then I can label it as a bulky uterus. Now you have to add 1 centimeter for these measurements if you are dealing with not a primary but a multigravida. So how to measure? Whether I have to now see whether I have to increase add the cervix in the total measurements. Yes, I have to add. This is what is written over here. The uterine length is measured in a mid-sagittal plane. In a mid-sagittal, first it should be the mid-sagittal plane from outer serosal surface of the fundus to the external os. It means that your cervix will include in the overall measurement of the uterus. So this way you will be measuring, and when you are measuring, please make a note that you have to take 3 measurements. You have to take 3 measurements, and 3 measurements can be taken in 2 sections, one transverse and one in longitudinal. This is in detail in your course. I will not elaborate over here because this is already in the course, how to take the measurements. So a note is over here that you have to take anterior posterior diameter, width, and the length, and all 3 cannot be taken in one section. You have to take longitudinal plus transverse section to take all measurements. Now I am counter questioning you. Can I take? You please, you all, whosoever is with me online, you please tell me, can I take measurement of length in a transverse section? Yes or no? In your comment box is yes. Now, yes or no? Repeating the question, can I take length in transverse section? Yes or no? I'm keeping an eye on Dr. Nidhi, Dr. Jagwati, Dr. Damyanti, Dr. Vatsalva, Dr. Srisha, Dr. Bani, Dr. Enough. Thank you very much. No. So I'm having an eye on the comment box also. No, so I cannot take length in a transverse section. I can take length in longitudinal section only. So if the answer to this question in one line is that if we are having more than what we have to, we should have in that will be bulky cervix or the bulky uterus, but you have to add 1 centimeter to this 7.5 if you are dealing with a multigravida uterus. Now in cervix, and one more important point is that you have to add the cervical length in that overall measurement of the uterus when taking the uterine length. Now the average length of the cervix, is in between 4 to 5 centimeters. So in a cervix, you will be labeling it as small, I mean decreased, if it is below 3. Now, if you are having a cervix which is more than 5 centimeters, that is bulky cervix. Now, there is something which is called as uterine length and uterine body cervical ratio. You can take a snipper shot of this over here. In the neonatological stage, the length should be this much, to body and cervix should be this much. You can take a snipper shot and you can paste it in front of your machine to see what is the ratio, whether this ratio is disturbed or not. And if you are, why this is important, if you are about to label a bulky uterus, the cervix to uterine length should be disturbed. So this way you will be labeling a case of a bulky cervix or a bulky uterus. And more important is, if you are dealing with a bulky uterus, you should search for a cause. What is the first cause, I will say, of bulky uterus? In your comment boxes, if you are having a bulky uterus and that uterus, I am giving you a tip also, and that uterus is not pear-shaped, because I know that pear-shaped uterus is normal shape of the uterus, and that is a globular shape. So question, if there is a bulky uterus and that uterus is not pear-shaped but a globular shaped, what can be the underlying cause of that bulky uterus? In your comment boxes now, hurry up. Adenomyosis, fibroid uterus? No, not the fibroid uterus, Dr. Rashid. Dr. Narvina. Fibroid uterus will not be a bulky uterus unless and until there are multiple fibroids. But adenomyosis, yes. Dr. Nidhi, it can be adenomyosis. Dr. Rashmi, yes, adenomyosis posting. Dr. Suresh, adenomyosis. And next 4-5 adenomyosis are posted by different doctors over here. So the more important is to search the cause of your bulky uterus, not just to label the bulky uterus. So when I say cervical length, this is the way when I will be how I will be measuring from internal to the external os. This way I have to measure. This thing is already discussed in your courses. And what is this? What is this over here? Now see, this is the cervix over here. This is the cervix over here. This is internal os, and this is the external os. Question: what is this line about? What is this hyperechoic line which is there in the cervix? In your comment boxes now, hurry up. Dr. Farheen, cervical canal. No, I'm saying this hyperechoic line. What is this hyperechoic line over there? Mucus plug, Dr. Nidhi. Yes. Dr. Atul, cervical plug. Dr. Vatsalva, cervical mucus. Very good. So this is the mucus plug. Now, can I say that when I am measuring the now, for example, I cannot make out where is the external os. Can I follow this cervical mucus plug? Yes, I will follow this cervical mucus plug to say where from to start and where to end when I am measuring the cervical length. So this was the detailed answer to this one-lined question, I will say. Next question is that how to visualize a suprarenal gland, Dr. Ajoy Kumar. So Dr. Ajoy Kumar is posting how to see for a suprarenal gland. Now, when I say this suprarenal gland, it is on the superior of the kidney, on the superior of the kidney. It is on the top of the kidney. Now, here comes the role of the spleen orientation. Now, this is the liver over here, and you have taken a long section of the kidney. Is this superior? Yes or no? No, this is not a superior. I should know why to search for. Then I will get it. I will not see for here. I will see for here, this side, because this side is superior, and because I am in the longitudinal section, so I will search for here and I will see this gland over here. Usually this is not seen on ultrasound, and if seen on ultrasound is abnormal. Mostly we are not seeing this much of prominent adrenal glands. So the basic question is where to see, not this side. This side is inferior. This side I have to see for this side because this is superior. See the importance of the screen orientation. So this was the question by Dr. Ajoy. So repeating that these adrenal glands are not very prominent, and if they are very prominent and you are easily seeing this, why to see? Toward the superior. Recall your screen orientation, and if your physics and machine settings course is active yet, I will request you, Dr. Ajoy, plus to those who are having confusion with the superior and inferior, please repeat the screen orientation from your machine and physics and machine settings course. It is in great detail over there. Next question from Dr. Nisha is that kindly describe steps for level 2nd. And second question from same doctor is that Dr. Nishi is that what is a biophysical score and what to see for in a biophysical score. This is what she is writing over here. Now, biophysical score. In biophysical score, we are having 1, 2, 3, 4, and 5 components. If I am seeing a component, I am giving 2 score. And if that is not seen, I will give 0. First is that I will be taking a fetal heart rate. This is actually an NST, non-stress test. And over here, I have to see 2 or more accelerations of 15 beats. Accelerations preceding the movements, that is non-stress test, NST. Preceding the fetal movements, I will be seeing an increase of 15 beats. That is for 15 seconds. That should last for 15 seconds within 30 minutes. Please take a snapshot of this and you can take a printout and you can paste it on the wall in front of your machine to see what I have to see over there. Now, if I am seeing these accelerations, I will use score of 2. And if I am not seeing this acceleration or I am seeing less of acceleration, I will give 0. Second is the fetal tone. Fetal tone, 1 or more episode of active extension or return to flexion in 30 minutes. So I have to see for 30 minutes this muscular tone. So active, now see, extension or flexion. This is the fetal muscle tone. And if I am seeing 1 in 30 minutes, then I will give 2. And if there is slow extension or partial, return, or if there is no muscle tone seen, then I will give 0. Third is the body movements. By body movements, I simply means that the movements of the fetal parts. If 3, now see, 3 or more in 30 minutes, then you can give 2. And if it is 2 and less, straightway 0. Now, the next is fetal breathing movements. Fetal breathing movements. What to see for fetal breathing movements? Can anybody tell me? Which structure I can follow, I can see to say? Listen to me carefully. Which structure in the fetal abdomen I can monitor, I can see for the fetal breathing movements? In your comment boxes now. Till then, I will elaborate this. If I will be seeing 1 or more episodes of fetal breathing movements in 30, lasting for 30 and more seconds in 30 minutes, 2. And if it is absent or less than, then 0. And amniotic fluid index. In amniotic fluid index, if it is more than 5, amniotic fluid index, I mean. Now you know what is amniotic fluid index and what is the difference between the maximum arterial fluid. So I am saying here amniotic fluid volume. If 5 and more, then 2. And if less than 5, then 0. Coming to my question, I told you that what structure I will be keeping an eye to see for these breathing movements. In your comment boxes now. Dr. Jagdevi, diaphragm. Dr. Vartika, diaphragm. Dr. Atul, diaphragm. Very good. And there are 5-6 doctors who are also posting this diaphragm. It is not sternum, Dr. Vartika. It is diaphragm. So I will be keeping an eye on the diaphragm to see whether the diaphragm is moving, and if diaphragm is moving, then I am having above fetal breathing movements. Next structure or next organ, I will say, next organ, what can tell me that the breathing movements are there? In your comment boxes now. Hurry up, hurry up, hurry up. Diaphragm accepted. Yes, diaphragm. One organ is over there where I can see for the breathing movements. Lungs? No, 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 not lungs. Some other organ is over there by which I can say that there are breathing movements, and that is very easy. Kidneys, yes. So I will be keeping an eye on the kidney, and if kidneys are moving up and down, it means that fetal breathing movements are there. So the point is over there that you have to, think more when you are holding a probe. So by seeing a diaphragm or by seeing a fetal kidney, I can say that there are fetal breathing movements. So this was the reply to this question, that how to see for this biophysical score. And next question is that level second scanning, what are the steps? Now see the steps, there is nothing steps for that you have to follow this checklist. No, you have to see for fetal head. What to see in fetal head? It is there in your course. Then you have to see for the face. If there is anything abnormal from face, then you have to see for the situs first. Okay, from abdomen, I mean, you have to see for the situs. Then you have to see for the abdomen. In abdomen, what you have to see first is the stomach bubble, whether it is present over there or I am having it displaced somewhere. Now, this all is in detailed fetal ultrasound. Then you have to see for a basic 4-chamber heart. Then you have to see for the limbs. In limbs, you have to at least see for the club foot, whether there is a club foot or not. So the moral of the story is that you have to see everything what is taught in your detailed fetal ultrasound course. So complete your detailed fetal ultrasound course, then you will come to know what I have to see over there. So that is what I am requesting time and again. Don't post a topic in a question and answer session. Complete your topic, and if you are having any doubt, you can get back to me. So whatever is taught in the level second, not the level second, we label it as detailed fetal ultrasound course. I'm sure that that doctor has not even touched the detailed fetal ultrasound course. So whatever is taught in detailed fetal ultrasound course, you have to see for all these things. Next question from Dr. Jagdevi is that concept of mirror imaging, edge shadowing. Now see. First of all, mirror image. Mirror image, it is actually an artifact. It is an artifact. Where I will be seeing this artifact? I will be seeing first the mirror of the image. That is what is written over here. Mirror image artifact. I will be seeing, for example, a liver. I will be seeing one more liver, but that is not actually liver. That is the, the image of mirror image, I will say, mirror image of that liver. Now, where from it is coming? When primary beam is reflected from such a surface, for example, a diaphragm, instead of directly going back to the transducer, it hits the another structure. So this is the brief, pathogenesis of this mirror image artifact, how it is looking like. So first of all, it makes a false assumption. It makes a false assumption that I am having two livers. Now see over here. This is liver over here. This is the diaphragm. And I will be having exact duplication of this image. Exact duplication of this image. Now see, I am having here portal vein, and this is the portal vein, this portal vein. So the exact mirror image of the liver seen on the other side of the diaphragm, this is called as mirror image artifact. Number one. Number second, ring down artifact. He has not posted ring down artifact. I'm adding on ring down artifact. Now, this ring down artifact is a reverberation, is actually a reverberation of common tail artifact. Now, how this is looking like? This is looking like this. So this is a ring down artifact. This is the ring down artifact. Now, edge artifact, edge down artifact is posted. Edge down artifact. Now, an edge down artifact is, first of all, what that is. Whenever there is a curved structure, try to understand, whenever there is a curved structure and that curved structure is having a fluid in it, from the edge of that curved structure which is having fluid, I will be having a shadow like. From the edge, I will be having a shadow like, and that's edge down artifact. How this is looking like, I will show you. Now here I am having, now see, this cyst, this bladder, or anything which is having fluid in it, and that is curved. From these edges, I will be having a shadow. Now see over here. From this, I will be having a shadow over here. This shadow. So this shadow is called as edge shadowing. Clear? Dr. Jagdevi has posted that. Now the last question, how to differentiate? It is posted by Dr. Imran. How to differentiate a hyperecho? Try to understand first question. How to differentiate calculus? For example, there is a calculus. How to differentiate whether this is a calculus or I am having something hyperechoic in somewhere in renal, somewhere in kidney, maybe in pyramid. Maybe I am having something in pyramid, in medullary calcinosis. I am having a hyperechoic medulla. How to differentiate it? Now see, this is the parenchyma. In this parenchyma, I am having a deposition of calcium. I'm having a deposition of calcium. But this deposition of calcium will not be in one part of the kidney and the rest will be normal. No, because the nephrocalcinosis refers to the deposition of the calcium which is there in the parenchyma of the kidney. It will not be restricted in one area only. But if I am having a calculus over here, it will be confined to one area only. So that is point number one. Point number second, if I am having nephrocalcinosis, the nephrocalcinosis will not have a shadow, whereas this calculus will have a shadow. Okay, so this way. Now, how much is the percentage? This is there in the abdominal course. Medullary nephrocalcinosis is having a 95% of chances are of medullary nephrocalcinosis, and cortical nephrocalcinosis is only 5%. So this way you can differentiate whether you are dealing with a nephrocalcinosis or a renal calculus. It is very easy. Second is that how to measure a Staghorn calculus. So the next question is how to measure a Staghorn calculus. Now in a Staghorn calculus, Staghorn is like my hand. Now see to my hand. So one stag over here, second stag, third stag can be this way, that way. Now I cannot measure it completely that it is 12 centimeters or anything, 15 centimeters. No, because now see. Try to understand. Because Staghorn calculus, this is the Staghorn calculus. This is the X-ray of the Staghorn calculus. On X-ray, I will look like a Staghorn, like it is a Staghorn only. But on ultrasound, what is happening? Now see, on ultrasound, the beam is coming and hitting this part, and not piercing in. How I will see this top? I will not see this stack. I will not see this tag. That is why on ultrasound, I will be seeing these semilunar multiple areas over here. Don't ever give a single measurement of a Staghorn calculus, because if your beam is hitting from this side, the measurement will be from here to here. Now from here to here, it can be a 15 millimeters or 15 centimeters, anything. So now if it is from here to here, 15 millimeters, now if the beam is hitting from here, now see, try to understand, from here, then I will be seeing this to this. And that will not be exact 15, that will be less than maybe 10 only. So the moral is that in Staghorn calculus, what you have to do, you have to take the longest measurement and the shortest measurement and then give in multiplication. For example, 15 into 5. That way, the smallest part of the Staghorn as well as the longest part of the Staghorn calculus is included. So this way, I have to see for the Staghorn calculus. Now, the grading of the liver, please go to the complete the class, complete the course. In course, what we are doing, we are taking these things in great detail. The next question from same Dr. Imran is how to grade for a fatty liver. In fatty liver, now see, in fatty liver, what I have to do, I have to see for the diaphragm. I have to see for the diaphragm. If diaphragm is seen, it means that the beam is penetrating, and that is why I am seeing the diaphragm which is below. That will be grade 1. For more detail, I am taking question and answer session only. There is a class of 30 to 35 minutes in abdominal ultrasound. Please complete that. So the moral is that I have to see for the posterior diaphragm. If diaphragm is seen, the grading will be less. Now, if the liver is very stiff, full of the fat, then the penetration will be low. And if penetration is low and attenuation will be high, then the posterior diaphragm will not be seen very clearly. So it all depends on the diaphragm, whether I am seeing the diaphragm or not. And if I am not seeing a diaphragm, then the beam is not penetrating my stiff liver, which is stiff due to high contents of the fat. So accordingly, I will be grading it. I will request you to complete the class in the abdominal course, which will be showing you patients, which will be showing you detailed PPTs, which will be showing you detailed theory of how to grade it. So this was all the list with me. I hope that you have got answers to your questions, and in future, if you will be having any question, don't hesitate to post in your respective batch WhatsApp groups. We are having many students as on date. I am having about 4,000 to 5,000 doctors, and we are running some 50 to 100 batches right now. So you are all added in your respective batch, WhatsApp batch, I mean the WhatsApp group according to the batch. If you are having any question or you need more explanation on your topic, anything, you can post it when we will be taking the interactive question and answer sessions. And very soon we will be announcing next interactive question and answer session for your batch. Thank you very much. God bless all of you.